Greetings. Let us talk about assessing cirrhosis and portal hypertension using liver stiffness measurement. These are my acknowledgements, and I would like you to read the notice. So, there are two important terms that have been defined recently. One is compensated advanced chronic liver disease. What does that mean? This is similar or equivalent to cirrhosis of liver, and cirrhosis requires liver biopsy. And can we get the same information by using various non-invasive testing to say whether the patient has cirrhosis? But because we don't take a biopsy to make the diagnosis, we try to use a different term, that is compensated advanced chronic liver disease, that is equivalent to cirrhosis of liver. So the second thing is, when patients with compensated advanced chronic liver disease are seen, do they have findings of portal hypertension that are clinically significant and at risk for portal hypertensive variceal bleeding? So, clinically significant portal hypertension. So, these are the two important terms that we should be comfortable with as we see patients with chronic liver disease. So, let us go through, review this concept. So, when you see a patient with liver disease, chronic liver disease, you assess inflammation by looking at their liver enzymes. Do they have hepatocellular injury? By looking at the AST and ALT, and the biliary injury by looking at the alkaline phosphatase. And if the injury has caused significant damage, that results in elevation of bilirubin. As the injury continues for a longer period of time, months, typically 6 months or longer, you may see that the stellate cells and myofibroblasts start forming fibrosis. And typically, we have assessed fibrosis in the past by doing a liver biopsy and looking at the classical features of cirrhosis, which will be defined by the presence of this disruption of the liver lobule, extensive fibrosis, bridging fibrosis from portal tract to portal tract to central vein, and formation of regenerative nodules. As the cirrhosis progresses, they develop portal hypertension that can be significant, in which case you may notice on endoscopy varices. So, can we get the same information without liver biopsy, without endoscopy, by non-invasive testing, so that we can start treating the patients to prevent portal hypertensive bleed using non-steroidal, non-selective beta blockers. So what we have learned in the recent past is that fibrosis can be assessed by by calculating the fibrosis score or FIB4 score using patient's age, AST, ALT, and platelet count. You could also assess fibrosis by checking the liver stiffness using fibroscan, and you could also assess the liver stiffness by doing ultrasound and assessing fibrosis using ultrasound or MRI. And as the fibrosis gets worse, patients develop portal hypertension, and as the portal hypertension becomes significant, patients may develop secondary hypersplenism and thrombocytopenia. So you check the platelets to check whether there is thrombocytopenia. And you could also check the portal hypertension by doing an ultrasound. Ultrasound will tell whether there is cirrhosis by looking at the liver surface, whether it's nodular or not. The sharp edge has been replaced by a blunt edge. The portal vein has become larger. The portal flow has reversed. The portal collaterals, portosystemic collaterals seen, and maybe free fluid in the abdomen. So typically when we see a patient with cirrhosis or suspected chronic liver disease, we look for clinical findings for cirrhosis that include palmar erythema, white nails, spider angioma, gynecomastia, caput medusae, testicular atrophy, shrunken liver on clinical exam by percussing the liver, splenomegaly, either by palpating or percussing the spleen, free fluid, and wasting. And then doing an ultrasound. If the ultrasound shows collaterals, you know that the patient has advanced liver disease and significant portal hypertension. So the first thing is you do an ultrasonography, which will give a lot of this information. Say, for example, the ultrasonography is not available locally, or ultrasonography doesn't show portosystemic collaterals and other things because of whatever reason. You could also assess the liver fibrosis by assessing liver stiffness measurement using FibroScan. So, using these various measures, when you see a patient with liver disease, you want to put them as into a box called compensated advanced chronic liver disease or not, and then if they have clinically significant portal hypertension or not. These two things are important for long-term management of the patient, and especially managing the patient so that they do not bleed from varices. So, compensated advanced chronic liver disease and clinically significant portal hypertension. So, how do you figure out compensated advanced chronic liver disease or clinically significant portal hypertension? Is starting with liver stiffness measurement, and then also looking at the blood count and checking the platelet count. So with this, you will know whether the patient has compensated advanced chronic liver disease and also that has gone to develop clinically significant portal hypertension. So if the liver stiffness measurement is below 10 kPa, and the platelet count is above 150K, you can pretty much say that this patient may have chronic liver disease, but not compensated advanced chronic liver disease. So below 10 kPa and platelet count of above 150 basically tells you that the patient does not have compensated advanced chronic liver disease. Without that, you won't have clinically significant portal hypertension. So when the patient has a liver stiffness measurement that has gone above 10 and below 15, so 10 to 15, and that indicates that the patient has compensated advanced chronic liver disease. In that patient, if the platelet count is well preserved, you can pretty much say that the patient does not have clinically significant portal hypertension. So liver stiffness measurement 10 to 15 or less than 15, well preserved platelet count above 150, no clinically significant portal hypertension, but the patient has compensated advanced chronic liver disease. Probable. If you take one step further, if the liver stiffness measurement increases beyond 15, 15 to 20, for sure the patient has established compensated advanced chronic liver disease. So above 15, between 15 to 20, for sure, compensated advanced chronic liver disease. And in this setting, if the patient has a low platelet count, very low platelet count, less than 110, then the patient has also clinically significant portal hypertension. So for the platelets to drop that much, there has to be enough portal hypertension and secondary hypersplenism to chew up the platelets. In this case, when the liver stiffness measurement is 15 to 20, platelet count of less than 110, you really don't need to do endoscopy. You can start with non-selective beta blockers to prevent variceal bleeding. If the patient is intolerant to non-selective beta blockers or for some other reason, uh, then you can consider endoscopy to look for varices, and depending upon the varices, you can decide about banding or not. So let's move on. How about liver stiffness measurement of about 20, 20 to 25? So any liver stiffness measurement above 15, in this case 20 to 25, patient has compensated advanced chronic liver disease. And in this case, mild decrease in platelets between less than 150, not necessarily has to be 110, less than 150. It establishes that the patient has clinically significant portal hypertension. Again, you start non-selective beta blockers. Endoscopy, whether to do or not, depends upon the patient's tolerance or any contraindications for beta blockers. You're seeing that we are looking at moving away from liver biopsy and moving away from endoscopy to manage patients with advanced liver disease based on these parameters. And this is especially important as we have a big obesity epidemic and chronic liver disease from metabolic associated liver disease. On the other hand, if you do liver stiffness measurement and it is very high, above 25 kPa, it indicates compensated advanced chronic liver disease and clinically significant portal hypertension without need for what the platelet count is. And in this case also, you start non-selective beta blockers and endoscopy if need be, based on whether the patient can tolerate the medication or not, or the patient has contraindications or not. So what did we learn? We use the emerging concepts are when you have a patient with suspected chronic liver disease, you see whether the patient has compensated advanced chronic liver disease or not, and whether the patient has clinically significant portal hypertension or not. Ultrasound helps by looking at the liver surface architecture, portal vein diameter, portal flow, collateral, spleen size, etc. And liver stiffness measurement and platelet count also helps. If the liver stiffness measurement is above 15, platelet count below 110, liver stiffness measurement of about 20, platelet count of less than 150, or liver stiffness measurement of about 25, irrespective of the platelet count, that indicates the patient has compensated advanced chronic liver disease along with clinically significant portal hypertension and will benefit from starting non-selective beta blockers. And the drug of choice is carvedilol. And should you do endoscopy in the ideal setting? Probably not. Should you do liver biopsy? Unless you have a definite reason, there's probably no need to do a liver biopsy to establish that the patient has cirrhosis. I've learned a lot from this beautiful review, and I want to thank the authors and hope this is helpful for you. Thank you.